Hey there, this is Jenny Chen. I'm the founder of 3D Heals. Welcome to the Lattice podcast, the official podcast for 3D Heals. This is where you will find fun but in-depth conversations with technological game changers, creative minds, entrepreneurs, rule breakers, and more, focusing on how we can use 3D technologies like 3D printing and bioprinting to reinvent healthcare and even life sciences. This podcast will also include AMA or Ask Me Anything sessions, past Instagram live interviews with influencers, and other direct engagements with our tribe.
So I don't know how this is going to work. We're live on YouTube, David. And I'm really glad to have this conversation with you today. So first of all, I want to introduce Devid Zille, who's actually a Dr. Devid Zille. And he was trained as a dentist and then went through quite a few, I would say, fellowship for craniofacial maxillary reconstruction surgery. But honestly, you started as a designer ever since you were 17. And so now you're fully invested in using 3D printing as part of your practice, as well as your ongoing entrepreneurship with companies. So you really started off as a designer first before you were a dentist and now a surgeon, craniofacial maxillary surgeon. So you want to just take us through that journey? Because it's such an
Sure. Yeah, thank you very much, Jenny, for having me here today. It's always a pleasure to talk to you and share a little bit of my story here with everyone. So yeah, you're right. Everything started as a hobby when I was on a young age, designing cars, designing car wheels. Then I started to go a little bit more pro on that designing aspect. But I got into dental school when I was 18 years old. So everything started there. So during the university itself, we didn't have a lot of technology implemented into the dental school. So everything was still manual. We need to do, by the end of my graduation, it's when all this software design is very archaic, I would say, but it's when the software is starting to get implemented into dentistry. That was 2009. So when I got into my residency program, I started in 2010, we still learn how to do things manually. So basically to do any type of planning on orthodontic surgery procedure, for example, we still need to get the patient x-ray, manually trace all the x-rays, and then we basically need to convert that 2D picture, which was an x-ray, into a 3D environment, which is the patient's face itself. So I tried to find a way to maybe let's bypass this manual tracing and let's add a little bit of more precision into it. So I started using Photoshop to designing my, or to basically trace my x-rays. So that's how everything started for me.
So David, before we move further, because some people don't understand the procedure and also what this disease that we're looking at, can you just explain to us what we're looking at here?
Oh, sure. Absolutely. So to be easy for understand here, I'm talking specifically for a type of deformity, a facial deformity, which is called a dental facial deformity, I would say, that requires orthodontic surgery to correct. So basically, what is a dental facial deformity? Is probably all of you guys already saw people walk in the streets with a protruded chin or with no chin or a no mid-face. So basically, this is not only a static procedure, but we need a lot of, there are a bunch of functional related issues to this type of deformity. So respiratory issues, occlusion issues, so the patient cannot bite quite well, cannot breathe quite well. And of course, at the end of this line, I would say we have the static component on that. But before aesthetics, we have a lot of function involved on those type of deformities. So basically, before we have virtual surgical planning in our favor, we basically need to do everything manually using dental casts. So we take impressions from the patient, we mount that into a device called articulator, and you basically move those segments manually using a roller and using super glue to put them in place. So that's how everything was done before. So independent if you were in United States, if you're in Brazil, if you're in Australia, all surgeons planned before orthognathic surgeries and to correct those type of deformities using this very archaic device called articulator and doing the manual movements.
Yeah.
So after 2010, I would say, we start to see some surgeons starting to publish 3D virtual surgical planning. So everything we started with Dr. Shaw and Dr. Gateno. They are now University in Houston, in Texas. So they were the pioneers in virtual surgical planning. So I have a big pleasure to be a friend of them, and they are basically the fathers of virtual surgical planning today in the world. They have more than 100 publications related to that for orthognathic surgery specifically. So to summarize here, basically this is one of the procedures that we can use 3D printing and virtual surgical planning in CMF. We can use that for correcting trauma, correcting this type of deformities, gender surgery. This is one of the things, there is one of the biggest trends in CMF today. It's gender surgery. So basically transgender patients, they have some facial characteristics that we need to improve on male to female conversion or female to male. So basically we can improve those facial aspects as well, and we can use virtual surgical planning on that aspect. So I see a lot of possibilities for using 3D printing and VSP, virtual surgical planning, in CMF.
So that sounds like the very first procedure that you were focusing on your career.
Correct.
Can you explain it to me why you moved to Houston? You moved to Dallas after you did your fellowship.
Correct. That's a pretty interesting possibility. That's a pretty interesting conversation. So everything started with this, I would say, prototypes of me doing some hobbyist things, not very professional in the beginning, for planning those surgeries. So then I moved to start to work a little bit with Blender, which is a free software that we have access to it, and a Brazilian software called Zilles. So basically we start doing the segmentation process. For those who doesn't know what segmentation is, basically a CT scan from the patient, it's a scale of blacks and whites and all this range of grays in between. So depending on the density of your bone or your soft tissue or air or in any structure, it has a very like a gray signature into that specific structure. So the software can open those images, but the software is not smart enough yet to know this is bone, this is soft tissue. So we do a process called segmentation, which is basically tells the software what is bone, what is soft tissue. So for that, there are some softwares like commercial off-the-shelf softwares that can do that, but they're pretty expensive, I would say.
Yeah.
So I started with Zilles, which is if I'm not wrong, is a PhD. It's a PhD. Is the result of a PhD program here in Brazil. So they developed this free segmentation software that we can export STLs from it. So that's how I start playing with 3D on the 3D environment. So we did all the segmentation using Zilles, which is a pretty good software, but it had some limitations. Of course, they didn't put a lot of effort on developing all these AI tools that, for example, Materialize have today. So, but it for simple things, you can do a lot of stuff.
Yeah, I mean, one thing when I'm looking at you, David, is you're already at the end of a journey to me, because I'm just starting to learn how to use CAD software, how to be a designer. I mean, I think a lot of clinicians will be in the same position like me, like we're not trained, and now we're just starting off. I think it will be helpful to go back to 17-year-old David, because you were doing something else with these software.
Correct. So before I started everything, even being studying to be a CMF surgeon, I was doing hobbyist and then going a little bit pro, as I said, and designing cars.
Right.
So basically, one of the nicest thing about this CAD softwares is independent of what you're thinking about, the tools are basically the same. So if you're planning to extrude a cutting guide, it's the same extrude command on the software if you're extruding a pin on a car, for example. So the tools are the same. So when I start looking at the possibilities in CMF surgery, basically I just use the same tools that I learned before by designing cars and car wheels and car parts before. Yeah. So it was basically changing a little bit the mindset of say, oh, maybe those tools or this thing that I had before could be useful on CMF using a concept that I never heard this before, but a concept that I think describes exactly what we're doing here, which is what I call surgeon-driven design. Mm-hmm. So I think this concept, go ahead.
Obviously, the human face is not a car, but the foundation that you had by designing cars really helped for you to be.
Oh yeah.
The whole thing is very intuitive for you. Not everybody, I'm pretty sure.
Exactly. So you're absolutely right. So starting designing cars and you start thinking, I think the shift where you change your mind into this is when you start thinking three-dimensionally. So because sometimes we're here thinking on something like a cutting guide, we just see that in 2D. Mm-hmm. And when we start seeing that, oh, maybe this on a 3D environment will work on a different aspect, you start thinking differently. And that's how I think things starting to move on specific implants.
I don't do surgery. I don't use surgical guide. So it sounds like you guys have 2D surgical guide, just like the X-ray cutting out silhouette.
So basically, before, when we have 2D images only, we do everything free-handed before.
Oh.
So everything was free-handed. So imagine working on someone's face free-handed, or no guided surgery. For me, that's craziness. I did a lot of surgeries free-handed, a lot of orthognathic surgeries free-handed, hundreds of those free-handed. But when you start using cutting guides and the positioning guides, I don't want to do that again. Absolutely not. So things get much easier. The morbidity on the patient is much smaller because you save time. And now the publications are coming and showing how much money insurances can save or hospitals can save on that aspect as well. So we see a lot of benefits, not only for the surgeon, but especially for the patient, but we see some indirect benefits for hospitals and insurances. So I think, as I was talking to some friends of mine, I think the virtual surgical planning and patient-specific implants will be the new gold standard, and the what people, all of them will be doing. All surgeons will be using this, especially in orthopedics and CMF and neurosurgery.
Yeah. I mean, I think for CMF in particular, your face is your identity, right? Like I can't imagine you mess up someone's chin. I'm sure that has happened before. Is that frequent?
Oh yeah.
So what are you going to do if you mess up someone's chin if it looks wrong?
Yeah, if you do that, unfortunately, you need to do another surgery to correct. So today there's some minor thing. If the deformity is very small, for example, it's 0.1 millimeters to the right, then you can use, for example, fillers or Botox to use that. So we are using Botox and hyaluronic acid in our practice today. But the thing is, there are some publications in regards of this small tweaks or small, I won't say errors, but small deviations for a plan. So there's a very famous publication on CMF surgery that's saying usually for a normal people, deviations bigger than 3 millimeters are perceptible. So if you have your midline, your upper midline deviated up to 3 millimeters for a normal person, is something that is not too visible. But for a doctor who is doing that every day, it's 1 millimeter is perceptible. So if we are talking about 0.2 millimeter deviation, even a surgeon, a well-trained surgeon, he cannot perceive that.
Yeah.
But another interesting, so for example, one of the references that we use a lot for deviations like that is, what is the name of that guy? Brad Pitt? No, not Brad Pitt. But It's a Hollywood actor.
Tom Cruise?
Tom Cruise. So yeah, Tom Cruise. Tom Cruise has like a 5 or 6 millimeter midline deviation on the top jaw. It's crazy deviated. So yeah, check a look later. You see how deviated he is.
Is he deviated because he's naturally deviated, or is
yes, naturally deviated?
Okay.
So he was born with that. So the publications today say, especially in orthodontic surgery, that 7 to 10% of the world population has a deformity in such a way that needs orthodontic surgery. So we are talking about hundreds of millions of people that needs this type of procedure. Of course,
Tom Cruise is not one of them. I mean,
actually, he is. If you want a surgeon, you definitely want to operate him. But he's fine on that.
That's a high stake procedure because it could be very good or it could be very wrong.
Yes, you're totally right.
He has one of the most attractive faces on earth with the deviation. So people will wonder, maybe.
You're right. Nobody right side or left side are the same. So if you get your face, your frontal view on Photoshop and flip it, you see that you're two different persons. Actually, 3 different people. So you have the right side, your normal, and your left side. Right. So absolutely different Jennies, I would say. But yeah, so everything started, as I said before, with designing car wheels. I started doing manual tracing and then moved into Photoshop tracing. And then I start to see, let's go 3-dimensionally and start playing with, initially with Blender and 3D Max. So that's how the first softwares that I started using. And then after you get your basis, you start to tweak and refine your modeling and using this concept that I just said, surgeon-driven design, which is basically DFAM, designed for additive manufacturing, but incorporating some subjects of surgery, for example, the size of your surgical approach, because I already saw, and you probably already saw, very nice plates or cutting guides, very nice images on the internet. Yeah. But imagine inserting that into a patient. To get a huge plate, sometimes you need to extend your surgical access. So sometimes engineers, they don't think, or they don't have that in mind, that, the surgeon will need to introduce this huge plate into a tiny surgical approach, because that's what the surgeon is usually used to doing in common free-handed procedures. So this is something that we need to think about. So there's for example, there's a surgical approach which we call Werber-Ferguson. Okay. So it's an approach for mid-face, which is basically when you do a cut here in the midline and you open your mid-face like this, one side to each side. Yeah. So basically, that's a pretty aggressive approach. So you can see everything.
What is that? What is the reason for that procedure?
Oh yeah, so we do that for removing tumors. So a lot of mid-face tumors or nasal tumors or sinus tumors, we use that approach, but for trauma as well. So we use that for trauma.
Yeah, I know about trauma. Yeah, this is a pretty prone to fractures and stuff like that.
Yeah, oh yeah, absolutely. So the nose bone here and the cheeks, the zygomatic bones, are definitely the most prominent bones to fracture in the whole body. So yeah, if the engineer doesn't have that in mind, that and design everything to be inserted through a Werber-Ferguson approach, everything it'll be easier. But we need to think about that sometimes. Let me just show you an example here. So this is just an example for a fracture here, a fracture here in the orbit. Sure. So if you need to open a whole Werber-Ferguson approach to put this, the patient will end up with a huge scar in the face. Yeah. But if you go and project a plate like this to go into a transconjunctival approach, which is inside the eye, and the patients end up with no scar, then we need to start tweaking and seeing that we need to do design for additive manufacturing for surgery, which is something that I don't see a lot.
I mean, that is super hard conversation to even find the right people to talk with, right?
That's one of the biggest difficulties.
An engineer who understands somewhat of human anatomy and surgical approach the surgeon have to communicate how you're going to get in. I mean,
Exactly.
a lot of investment on both ends to spend time with each other. I mean, obviously, it's ideal to have someone like you who can do both, basically. But that would be an on one.
Exactly. You're totally right. So I think investment on education on that part, and I think 3D Hill is doing this brilliantly. But education for me is the key for success in this, especially now that we see point of care 3D printing and 3D printers in hospitals and clinics. We need that. And I think this is the biggest bottleneck on implementing this on a bigger. Of course, we are not asking to have metal 3D printers at hospitals, for example, to do cases like this, which are metal 3D printed. It's a huge investment. It's an investment not only in resources, but also human resources. But if surgeons started to think about and training, and some of them designing, and which we see here in Brazil, it's starting to happen. Some surgeons being more involved in designing, things will be much bigger, and we spread this technology, which for me, it's the fourth industrial revolution, I would say.
Actually, I was going to ask you about that because, actually, I have a lot of plastic surgery friends. It told me that 3D printing was used in the 1980s, basically when 3D printing was invented. I mean, it's not like they're actually familiar as an industry, but it's just not spread. So my question now is, do you know what is the current percentage or somewhat of assessment of how many surgeons in CMF actually use 3D printing as a technology?
Let's use the U.S. market, which is I am more familiar with. So in 3D printing in the U.S. market for orthodontic surgery, I would say that today for normal splints, which is the simplest device that we can 3D print, I can tell you that probably about 40 to 50% in the U.S. are already doing splints for orthodontic surgery, because we have pretty good companies doing that. So 3D Systems is doing that, Materialize is doing that. So in the US, it's something that is pretty big. For example, and I like to consider this as an evolutionary step. So we start with cutting guides, then we go for metal 3D printed guides, then we go for patient-specific implants. I think in the US, it's about 40 to 50%. But if you're talking about, for example, South Korea, which almost 90% of the orthodontic surgeries are already patient matched, we see that depending on the market where you are, we see things moving. And I believe in 10 years, US will be like that.
That's why South Koreans look good.
Yeah, you're right.
Because they're corrected now. Everybody have the perfect.
Oh yeah, I see this trend in South Korea. People are looking aesthetics. It's something big in South Korea, right?
Yeah,
that's something.
I totally forgot that Brazil is actually also one of the major place for plastic surgery.
Oh yeah, plastic surgery and CMF surgery. Brazil, it's one of the biggest trends. So for plastic surgery, we have Dr. Ivo Pitangui here, which unfortunately just died 2 years ago. But he was one of the fathers of modern plastic surgery. He was based in Rio, and a lot of people all around the world come to his facility to be trained by him. And we have a lot of people in Brazil in CMF as well doing this. So I see 3D printing being implemented not only for CMF, but this, for example, this is a case that I helped working a couple of years ago for spine surgery. So we did a bunch of these. So you're familiar with this, right?
That's something I would like to do. Now the question is, okay, if we want this technology to be adopted, and I know a lot of younger surgeons or doctors or radiologists want to get into the space to know beyond just looking at images and reconstructing at it. What can they do? What kind of advice would you give them to start off?
I think, first of all, they need to have Let me see here. That's a good question, I would say. I think they need to start thinking outside of the box on not only taking a look at gray images, which radiologists are more familiar with. So I think they need to start seeing stuff outside of medical device areas. So there's a big speaker here in Brazil that he invented a term called combinativity. So it's basically a combination between creativity and combination. So combinativity,
Okay.
combination and creativity. So you're looking stuff or trying to find stuff in other areas and bring into yours.
Yeah.
So that's how I started. So if you go to YouTube and try to find tutorials on how to design or how to model a plate for a neurosurgery procedure, you never find. But if you take a look, at how a guy can design a rib for holding a motor in a RC car, you will find on YouTube. So I think you need to start taking a look and see, maybe I can use this concept and apply that into my reality and my daily basis procedures. Because as you said, and as we talked before, you won't find things related to health on YouTube, especially because there are companies related. So there are a bunch of
Surgery stuff.
investment that company put on this. So they won't reveal their gold secrets. So I think.
I totally agree, and that's one of the most inspirational thing I've heard today, and I think a lot of people will appreciate that. I mean, essentially, it's a way of a copy and paste, but creatively. I do that all the time.
You're right.
Paste. So
yeah.
So let me take a look at YouTube channel and see if we have any questions.
Sure.
Okay, I don't think there are people.
Yeah, I think this is more recorded live instead of being on Instagram.
Yeah.
But I think you can post this live on the Instagram account, right?
I can. Yeah.
Yeah,
So,
you'll be much better.
Yeah. Well, thank you very much, David, for joining me today. I'd love to engage you for other webinars and interviews.
Absolutely. You can count on me for anything. I appreciate a lot of your comment. I'm really sorry about this issue with Instagram, but I think we can spend here the whole day talking about this.
Yes.
And please feel free always to reach me if you need anything else. If you want to organize another webinar like this to be more focused on CMF, not generalistic, I'd love to.
I have an idea for you. I'll email you.
Perfect.
My thing is I'll talk to an influencer and then learn from them and do something about it and not just listening. So maybe I'll go and start learning Meshmexer and Meshmexer how to make the things I'm thinking about making today.
Okay, sounds good.
How to copy and paste. So.
Okay. All right. Thank you very much, Jenny.
Yeah.
Have a good one.
Okay. You too. Bye-bye. Stay safe. Okay. Bye.
That's it for this episode. Be sure to follow us on Facebook, Twitter, and Instagram at 3D Heals, and check out the links in the show notes. See you next time.